Welcome back to the deep dive. Today, we are taking a truly foundational leap into infectious disease.
We're focusing specifically on HIV infection and AIDS.
Exactly. And if you are a medical learner, someone who really needs to master the clinical concepts, the staging, the pharmacology, all the stuff you absolutely have to nail for your exams and your rotations.
Then this deep dive is, well, it's built for you.
Our mission today isn't just to, read a chapter out loud.
No, not at all. We're trying to give you the cognitive frameworks, the metaphors, the anchors that let you turn these dense textbook sections into something you can actually recall on the ward.
We're basically modeling this on the core concepts you'd find in a text like Davidson's.
And we have to start with the big picture, the context.
We really do.
Yeah.
Because this is a disease that has been completely redefined in our lifetime.
Absolutely. Thanks to highly effective combination antiretroviral therapy, or ART-T, HIV has gone from being this relentlessly progressive, almost always fatal illness
to what it is now, a chronic, manageable condition.
Exactly. Where patients can achieve a near normal life expectancy. And that transformation, that context, is maybe the most important anchor of all.
Okay, so let's set the scene. Where does the story of this virus begin?
Well, clinically, AIDS was first recognized by doctors in 1981. They saw these strange, opportunistic infections popping up in young men.
But the virus itself was around long before that.
Oh, much, much longer. Researchers have actually traced the earliest documented case of human HIV infection back to a blood sample.
From where?
From the Democratic Republic of Congo, way back in 1959.
Wow, 1959. So it was simmering for decades before it really exploded onto the global scene.
Precisely. It wasn't a sudden appearance, more of a slow burn that finally reached a critical mass.
And the origin, of course, is zoonotic. It jumped from animals.
That's right. It didn't start in humans. It evolved from something called simian immunodeficiency viruses, SIV, which are found in African primates.
And there are two main types, right?
Yes. The one that's responsible for the vast majority of the global pandemic, that's HIV-1.
And that came from chimpanzees.
It jumped from chimpanzees. Then there's a second, much less common type, HIV-2.
Which tends to be, less aggressive?
Slower to progress and less transmissible. It's derived from sooty mangabey monkeys and is still largely restricted to West Africa.
So let's talk about the scale today. It's still just staggering.
It is. Looking at the recent global estimates, you've got nearly 40 million people living with HIV worldwide.
A massive number.
Yeah.
But the trends tell a story of incredible success, don't they?
They really do. Since the peak of the epidemic back in 2004, AIDS-related deaths have been more than halved.
And new infections.
New annual infections have dropped by about 40% since the late 90s.
So this creates a really interesting kind of counterintuitive point that we have to grasp.
It does. And it's a crucial one for understanding public health messaging. The incidence, that's the rate of new cases.
That's going down.
Thankfully, yes, it's decreasing globally. But because RT is so good at keeping people alive and well,
the total number of people living with HIV is actually going up.
Exactly. The overall prevalence is increasing. And that increase is actually a metric of success. It's a sign of successful chronic disease management.
That's a fantastic point. Now, when we talk about HIV-1, it's not just one single virus, is it?
Not at all. We're mostly talking about HIV-1 group M, but even within that, there are subtypes, and geography really matters.
So what's the big one?
Subtype C is the heavyweight. It dominates in sub-Saharan Africa and India, accounts for roughly half of all infections globally.
And it's known to be particularly transmissible.
It is. Then you have subtype B, which is what you typically encounter across Western Europe, the Americas, Australia.
And do these subtypes behave differently in the body?
It seems so. Researchers have noted that some, like subtype A, are linked with slower disease progression, while others, like subtype D, seem to cause a faster decline. It just highlights the incredible genetic variability of this virus.
Okay, let's shift gears to transmission. This is where we really apply those public health principles.
Right. We all know the routes: sexual contact, blood exposure, and mother-to-child transmission.
But to counsel patients effectively, or, to understand your own risk as a healthcare worker, we need to internalize the actual numbers.
This is where we need an anchor. Let's call it the transmission risk index.
Okay, the risk index.
And the key thing to remember is that risk is not linear. It depends on two things: the type of exposure and, critically, the viral load of the source person.
This is the UVU message, right?
Exactly. Undetectable equals untransmittable. If the person living with HIV is on successful ART and has an undetectable viral load, The risk of sexual transmission is essentially zero. That has revolutionized prevention.
But looking at the historical data, before ART was widespread, the differences between routes were huge.
Yeah.
What was the single highest risk?
Oh, easily blood transfusion. A single unit of contaminated blood carried something like a 90% transmission risk.
90%.
That one number explains why widespread blood screening, starting in the mid-'80s, was one of the single most effective public health interventions in history. It basically eliminated that route in high-income countries.
Now compare that 90% to, say, a needle stick injury in a hospital.
A percutaneous needle stick is estimated at just 0.3%, a huge difference.
And what about sexual exposure?
The risk per act is much lower, but of course, cumulative risk builds up over time.
And the type of act matters.
A lot. Receptive anal intercourse has the highest per act risk, around 1.4%.
Okay, 1.4%.
And vaginal, male to female vaginal transmission drops to about 0.1%, and female to male is even lower, around 0.05%. So these are low probabilities for a single exposure, but at a population level, they drive the epidemic.
And what are the clinical factors that can, push those numbers up?
The universal factor is a high viral load in the source person. That's the engine of transmission, always.
And beyond that?
For sexual contact, any coexisting sexually transmitted infections, especially those that cause genital ulcers, they dramatically increase both susceptibility and infectiousness.
Because they break down the mucosal barrier.
Precisely. Anything that compromises that integrity, like lacerations, raises the risk.
So this is a perfect spot for our key takeaway one.
I think so. Global HIV stats have been totally changed by RT.
Incidence is down, prevalence is up. That's the sign of a successful chronic disease model.
And when you're thinking about risk, it's always about the type of exposure combined with the source's viral load. That's what determines the probability.
Perfect. Okay, let's zoom in now. Go from the population level right down to the microscopic.
Let's look at how this virus actually works. And to do that, we're going to use a metaphor.
I like metaphors. What is it?
We'll call it the CD4 cell factory takeover. It helps visualize the retroviral life cycle, which is absolutely essential for understanding where our drugs work.
So the basics. What kind of virus is HIV?
It's an enveloped RNA retrovirus. It belongs to the lentivirus family. Lenti means slow, which reflects that long incubation period before it causes severe disease.
And what does it look like?
It has a lipid membrane on the outside, which it steals from the host cell. And studying that membrane are these protein spikes, GP120 and GP41.
Inside that.
You've got the inner core, this conical shape made of P24 protein. And inside that core is the payload.
Which is?
2 copies of the RNA genome and the 3 enzymes that make the whole process possible. Reverse transcriptase, integrase, and protease.
Okay, so let's walk through the factory takeover step by step. 6 stages.
Stage 1, attachment. The virus's surface protein, GP120, acts like a key searching for a very specific lock.
And that lock is the CD4 receptor on the host cell.
Exactly. The CD4 receptor is the front door to the factory, the T helper lymphocyte.
Stage 2, entry and fusion.
Yeah.
So binding to CD4 isn't quite enough to get in.
No, it's the first step. That binding causes a shape change in GP120, which then lets it grab onto a second receptor, a co-receptor.
Usually CCR5, right?
In the initial stages of infection, yes, it's usually CCR5. Binding to that co-receptor is the real key turn that lets the other protein, GP41, spring into action and fuse the viral envelope with the cell membrane.
And the core gets injected into the cell cytoplasm.
That's it.
And we had to pause here because that CCR5 co-receptor is fascinating.
It really is, because a small percentage of people, particularly those of Northern European descent, are homozygous for a mutation called CCR5 delta 32.
Which means they just don't have that co-receptor on their cells.
Correct. They're missing the second part of the lock, and that makes them virtually immune to the most common strains of HIV. It's a natural genetic defense.
Incredible. Okay, the virus is inside. Stage 3.
Stage 3, reverse transcription. The virion uncoats, and the most famous enzyme, reverse transcriptase, or RT, gets to work.
It takes the viral RNA and does what?
It synthesizes a complementary strand of DNA from it. It's doing the reverse of what a normal cell does.
And it's messy. It makes a lot of mistakes.
Incredibly error-prone. It has no proofreading function like our enzymes do, and that's a critical feature of the virus.
Why is that so important?
Because every single time the virus replicates, RT introduces mutations. This creates this huge cloud of slightly different viruses, this viral heterogeneity.
Which lets it escape the immune system and our drugs.
Precisely. This step, gumming up this copy machine, is the target for 2 big classes of drugs: the NRTIs and the NNRTIs.
Okay, so now we have a DNA copy of the virus. Stage 4.
Stage 4, integration. The new viral DNA gets shuttled into the nucleus of the host cell, and there, the second key enzyme, integrase, performs the installation.
It physically splices the viral DNA into the host cell's own chromosomes.
Yes, it becomes what we call proviral DNA.
And this is the point of no return.
It really is. Once it's integrated, that cell is permanently infected for the rest of its life. It now carries the viral blueprint.
And that enzyme, integrase, is the target for
The highly effective integrase inhibitors.
Got it. Okay, stage 5, replication and assembly.
The integrated provirus can lie dormant, or if the T cell gets activated, it springs into action. The host cell's machinery is hijacked.
It starts making viral parts.
It transcribes viral mRNA, which is then translated into these long, non-functional viral polypeptide chains.
So they're like long strings of beads that need to be cut.
Perfect analogy. And that cutting is done by the third key enzyme, protease. We call protease the assembly line cutter.
It chops the long chains into individual functional proteins.
Right. The P24 core, the RT, the integrase, all the bits and pieces. And if you block that step, you get immature non-functional viruses.
Which is the target of the protease inhibitors.
Exactly.
And finally, stage 6, budding and release.
These new, fully assembled infectious virions then bud from the cell surface, stealing a piece of the host membrane as their new envelope.
And they go off to infect the next CD4 factory.
And this cycle happens on a truly massive scale. Even when a person is totally asymptomatic, we estimate that about 10 billion new virions are produced every single day.
10 billion. And about a billion CD4 cells are destroyed. The immune system is just in this constant state of war.
It is.
Now, there's a key point here. The virus itself isn't what's directly killing most of those CD4 cells, is it?
No, that's a really common misconception. The primary driver of CD4 cell death is actually the body's own immune response.
It's friendly fire.
It's friendly fire. The CD8 cytotoxic T cells recognize the infected CD4 cells and kill them. The body's attempt to control the virus is what ultimately causes the immune system to collapse.
And all the while, the virus is using that error-prone RT to keep changing its coat, changing those GP120 spikes, so the CD8 cells are always a step behind.
It's a master of evasion.
Which brings us back to latency. Why can't we just cure this with RT?
Because of this anchor, latently infected cells are sanctuary sites.
What does that mean?
Once that proviral DNA is integrated, a small number of those T cells can go into a resting, non-replicating state.
A latent state.
Yes. And since RT only targets the active replication steps, RT, integrase, protease, it has zero effect on these latent cells.
They're completely invisible to the drug.
Exactly. They form a long-lived reservoir that prevents eradication and is the reason why therapy has to be lifelong.
And the long-term consequence of all this is the slow, grinding attrition of the CD4 T helper cells.
Which leads to that profound deficit in cell-mediated immunity. That's why you see diseases caused by mycobacteria, fungi, herpes viruses.
But it's not just the T cells that are affected.
No, there's also a secondary defect in B lymphocyte function. They don't make antibodies as well.
And clinically, that means
a significantly higher risk of infections from encapsulated bacteria, most notably Streptococcus pneumonia. So patients with HIV get a lot of bacterial pneumonia.
And even with successful RT, when the virus is undetectable, the fight isn't completely over, is it? There's this residual inflammation.
This is a critically important concept for modern HIV care. The immune activation never fully quiets down.
And that chronic low-grade inflammation has consequences.
It does. It's linked to an accelerated rate of non-communicable diseases. We see more ischemic heart disease, more strokes, more chronic kidney disease, more non-AIDS cancers compared to the general population.
So the job of an HIV clinician today is not just about opportunistic infections.
Not anymore. It's about managing complex, chronic diseases driven by this persistent inflammation.
Okay, that tour of the factory takeover is absolutely foundational. Before we move on, let's do a quick check-in to make sure those drug targets have landed.
Good idea.
So if you were designing a drug and your goal was to act like a factory floor supervisor to stop the new viral proteins from being correctly assembled into functional parts, which class of antiretroviral drug would you be developing?
Pause.
The answer there is protease inhibitors. They are the assembly line cutters in stage 5. If you didn't get that, it might be worth rewinding and listening to that section on the factory takeover again.
Understanding where the drugs work is key.
Absolutely. Okay, so we know how the virus works. Let's talk about how we track the damage and monitor the patient. Let's talk about the scorecard.
Right. So diagnosis. The trend globally is moving towards universal testing, just making it a routine part of care.
But in many places, like the UK, it's still more targeted, right?
Yes, often prioritized in high-prevalent settings. Sexual health clinics, drug dependency programs, or for any patient who presents with symptoms that might suggest an underlying immunodeficiency.
And the tests themselves, they've evolved.
They have. We mostly use lab-based ELISA or rapid point-of-care tests that detect antibodies, but the modern screening tests do more.
They also look for the P24 antigen.
Yes, because P24 is a viral core protein that spikes really early during the primary infection, even before the antibody response is fully mature. So it closes that diagnostic window.
And for final confirmation.
You need 2 positive antibody tests from 2 different types of immunoassays.
What about in newborns? That's a special case.
It is, because a baby born to an HIV-positive mother will carry her antibodies for up to 15 months.
So an antibody test would be a false positive.
Exactly. So in infants, we rely entirely on nucleic acid amplification tests, or PCR, which detects the actual viral RNA. It bypasses the whole antibody issue.
Okay, so once you have a diagnosis, there are 2 numbers on the scorecard that matter more than anything else.
2 critical numbers. The first is the CD4 count. This is your immune strength indicator. It tells you how much damage has been done.
It's measured by flow cytometry. A normal count is generally over 500 cells per cubic millimeter.
And this leads us to probably the most important clinical anchor in this whole deep dive.
Which is?
The T-cell tiers of terror. This is your risk stratification tool. It dictates everything from prophylaxis to prognosis.
Okay, let's break down the tiers. Tier 1, CD4 count is above 500.
At this stage, your risk of a major opportunistic infection is very low, but you're not completely out of the woods.
You start to see things like what?
Higher rates of bacterial pneumonia, shingles, oral thrush. It's the first sign that the immune system is starting to feel the strain.
Then we get to the next tier, the real inflection point, 200 to 500.
This is the zone of moderate immune suppression. This is where pulmonary TB becomes a huge threat. It's the point where we become very vigilant.
But the really classic AIDS-defining illnesses usually wait for the next tier.
They do. And that final, most dangerous tier is a CD4 count below 200.
This is the zone of severe immune suppression. The risk for AIDS-defining illnesses just skyrockets.
This is where you see pneumocystis pneumonia, PCP, esophageal candidiasis, HIV wasting syndrome.
And it gets even more critical as you go lower.
Yes, below 100 is where the really severe things happen. Cerebral toxoplasmosis, cryptococcal meningitis, disseminated MESI.
So those tiers 500, 200, 100 are absolutely essential to memorize.
They are the foundation of clinical management.
Now for the second number on the scorecard, the viral load, or VL.
And this is our ART efficacy indicator. It doesn't tell you about the state of the immune system. It tells you how well the treatment is working.
It's measured by PCR, looking for the actual HIV RNA.
And if it's high at baseline, say over 100,000 copies per ml, that predicts a very rapid CD4 decline if you don't treat.
But when you're monitoring treatment, the goal is to get it to 0, or undetectable.
Undetectable, yes. The goal of RT is to drive this number down so low that the test can't find it.
Okay, and finally in this section, let's talk about the clinical staging systems.
The WHO and CDC systems. They provide prognostic information, and for this, we need another anchor. We'll call it the permanent marker rule.
The permanent marker rule. I like it. What is it?
It means that a patient is permanently staged by the most severe thing they have ever had.
So if a patient gets PCP, which is a stage 4 illness, and then they get on RT and their immune system completely recovers, they're still stage 4.
Forever. They never revert to an earlier stage. That stage 4 diagnosis is like a permanent marker on their clinical record.
Okay, so let's quickly run through the stages. Stage 1 is asymptomatic, or maybe some swollen glands.
Right. Stage 2 is where you see those minor symptoms. Moderate weight loss, recurrent shingles, persistent oral thrush.
Stage 3 is getting more severe, big weight loss, over 10%, chronic fever or diarrhea, and, importantly, pulmonary TB puts you in stage 3.
Correct. And stage 4 is the list of AIDS-defining conditions we've been talking about. PCP, esophageal candidiasis, Kaposi's sarcoma, toxo, and so on. Crossing that threshold changes everything.
All right, let's try a quick check-in on that. A patient presents with shingles on their chest and persistent oral thrush, but they feel generally okay. Which WHO clinical stage and CD4 tier would this most likely correspond to?
Cause.
So that would be stage 2. The combination of shingles and thrush is classic stage 2. It's not an AIDS-defining illness, so it's definitely not stage 4.
And their CD4 count would likely be below 500, but probably still above 200. It's a sign that things are heading in the wrong direction.
Perfect. So now that we have the scorecard, let's pivot to the clinical face of HIV, using those tiers to guide us through the spectrum of disease.
Right. Let's start at the very beginning. Primary HIV infection.
The seroconversion syndrome. This happens a few weeks after exposure.
2 to 4 weeks, yes. It's symptomatic in over half of people, but it's so often missed.
Because it looks like what?
It looks like glandular fever, infectious mononucleosis, fever, sore throat, malaise, swollen glands.
So what's the clinical red flag? How do you distinguish it from mono?
The big giveaway is a maculopapular rash or mucosal ulceration that strongly suggests primary HIV. In classic mono, you only get a rash if someone mistakenly gives the patient amoxicillin.
And you diagnose it early with a PCR test or P24 antigen.
Correct, before the antibodies have even had a chance to develop.
Okay, moving on from primary infection, let's talk about the specific problems that bring patients to the clinic. What about lymph nodes?
Persistent generalized lymphadenopathy, or PGL, is really common in asymptomatic infection.
But when do you worry about a swollen lymph node?
You worry if it's growing rapidly, if it's asymmetric, or if it's very large. That could signal a malignancy like Kaposi sarcoma or lymphoma.
Or TB?
Or TB. In fact, TB is an extremely common cause. The nodes are often matted together and fluctuant, and you need to aspirate them, not cut into them.
What about weight loss?
It's very common in advanced infection. When you have more than 10% weight loss plus chronic diarrhea or fever, that's HIV wasting syndrome, which is AIDS defining.
But you have to rule other things out first.
It's a diagnosis of exclusion. Rapid weight loss, more than a kilogram a month, usually means there's a major OI or a cancer hiding somewhere.
And fever, the classic PUO, pyrexia of unknown origin.
In low and middle income countries, the #1 cause is TB. Always think TB. Sometimes you just have to empirically treat for it after you've sent off the cultures.
And in high-income countries.
Disseminated Mycobacterium avium complex, or MC, becomes very important. That often presents with fever, diarrhea, and a big spleen.
Let's talk about the skin. Mucocutaneous disease.
This is so important. A simple inspection of the skin and mouth can give you huge prognostic clues.
Like what?
Seborrhoic dermatitis. It's common, but its severity directly tracks with how low the CD4 count is getting.
Herpes simplex too.
Recurrent, yes. And when the ulcers become really extensive and persist for more than 4 weeks, that becomes an AIDS-defining condition.
And shingles. We mentioned shingles is a marker for a CD4 around 350.
Exactly. And in advanced disease, it can be multidermatomal, recurrent, and has a very high risk of postherpetic neuralgia.
And then there's the signature malignancy, Kaposi sarcoma.
KS. It's a spindle cell tumor caused by human herpesvirus 8, HHV8. In the context of AIDS, it's always multicentric.
And it looks like what?
Typically red-purple lesions. They can be flat, raised, or nodular, and they can ulcerate.
And it's not just on the skin.
No, it commonly spreads to the GI tract and the lungs. The good news is it often responds really well to ART alone, just by restoring the immune function.
Okay, let's look in the mouth. What are the key oral conditions?
The most common is oropharyngeal candidiasis, thrush. Pseudomembranous thrush, these white patches that you can scrape off.
And if the patient has painful swallowing?
Then you have to assume it's spread to the esophagus. Esophageal candidiasis is AIDS-defining and needs systemic antifungal therapy.
What about oral hairy leukoplakia?
OHL. It's these corrugated white plaques on the side of the tongue. It doesn't scrape off. It's caused by the Epstein-Barr virus, and it is virtually pathognomonic of HIV infection.
Okay, moving down to the GI tract. We talked about esophageal candidiasis. What if that doesn't get better with treatment?
If it's not responding to ezols, you need to do an esophagoscopy. You're looking for other causes like huge aphthous ulcers or, more commonly, CMV ulcers.
And what about chronic diarrhea?
You have to figure out if it's large bowel or small bowel.
Large bowel suggests what?
Bacterial pathogens like Salmonella, Shigella, or if the CD4 count is below 100, CNV colitis. On biopsy, you see those classic owl's eye inclusion bodies.
And small bowel watery diarrhea.
Well, it could just be HIV enteropathy, which is a diagnosis of exclusion, but usually it's due to unicellular parasites.
The big three being?
Cryptosporidiosis, microsporidiosis, and cystosporiasis. You also have to think about disseminated MAC in this context.
And we can't forget the liver. Hepatitis B and C co-infections are common.
Very common due to shared risk factors. And the HIV co-infection makes both hepatitis B and C much worse. It accelerates liver fibrosis and increases the risk of liver cancer.
And there's a critical clinical pearl here for treatment.
There is. If your patient has both HIV and active hepatitis B, their RT regimen must include tenofovir, which is an NRTI that is active against both viruses.
Let's move to the lungs. This is a huge topic. The big three causes of admission are bacterial pneumonia, TB, and PCP.
And we can use an anchor here to differentiate them. The acute, subacute, chronic triad.
Okay, bacterial pneumonia is.
Acute, it comes on fast. The patient is very breathless. They have a high white cell count, and the chest x-ray shows consolidation.
Now, PCP, pneumocystis pneumonia.
This is subacute. The shortness of breath develops over winds, usually less than 12. The white cell count is often normal.
And the x-ray.
The classic finding is bilateral interstitial infiltrates, what we call ground glass opacification on a CT scan. You need induced sputum or a lavage to diagnose it.
And the treatment is high-dose cotrimoxazole and steroids if they're hypoxic.
Correct.
And finally, pulmonary TB in advanced HIV.
This can have a variable duration, but the key is that the presentation is atypical.
How so?
You rarely see the classic apical cavities. Instead, you see infiltrates that are not in the apex. You see pleural effusions, and you see big hilar lymph nodes.
And the sputum smears are often negative.
Often negative, which makes diagnosis really hard. The urine lamb assay can be a lifesaver here for rapid diagnosis.
Okay, let's move to the nervous system, the brain and the eye.
A very common site for complications. It can be direct effects of HIV or opportunistic diseases.
Let's start with cognitive impairment.
It's a spectrum from asymptomatic all the way to HIV-associated dementia, or HAD.
What kind of dementia is it?
It's a subcortical dementia, so it affects executive function, psychomotor speed. On an MRI, you just see diffuse cerebral atrophy.
It often improves with art.
It does. Now, for the really high-stakes topic, space-occupying lesions, or SLLs.
This is where we need that diagnostic anchor, differentiating the top two causes.
This is absolutely essential. We have to be able to tell the difference between cerebral toxoplasmosis and primary CNS lymphoma on a brain scan.
Okay, cerebral toxoplasmosis.
This is the most common cause. It's a reactivation of latent Toxoplasma gondii cysts.
And the imaging shows.
The classic pattern. Multiple ring-enhancing lesions with a lot of surrounding edema.
And because it responds so well to treatment, you often just treat empirically.
Exactly. You give a course of therapy, and if the patient gets better in a week or two, that confirms the diagnosis.
And its main mimic, primary CNS lymphoma or PCNSL.
This is a high-grade B-cell lymphoma linked to EBV, and the imaging is different.
Sure.
It typically shows a single homogeneously enhancing periventricular lesion, so one lesion, not many, and it's often right next to the ventricles.
And you can test the CSF for EBV DNA.
Yes, finding EBV in the spinal fluid strongly supports the diagnosis.
That distinction, multiple ring enhancing for TOPSO, single periventricular for PCNSL, is just invaluable.
It's one of the highest yield facts to know.
What about meningitis?
The most common cause is cryptococcal meningitis. It's a subacute presentation, headache, vomiting, but neck stiffness is often absent.
So it's easy to miss.
Very easy. You need a high index of suspicion. The CSF cryptococcal antigen test is fantastic, very sensitive and specific.
And finally, the eye. What's the main danger there?
CMV retinitis. It causes painless progressive visual loss in patients with severe immune suppression.
And on fundoscopy.
You see hemorrhages and exudates. It's sometimes described as frosted branch angiitis. The devastating thing is that any vision that's lost does not recover.
A real emergency.
Absolutely.
Okay, we have navigated the treacherous landscape of opportunistic infections. Now, let's talk about the counterattack, prevention and antiretroviral therapy.
This is the success story. RT has turned this whole field on its head.
So what are the main goals of RT?
There are three. 1, get the viral load to undetectable. 2, get the CD4 count to recover, ideally above 200. And 3, reduce the transmission risk to 0.
And the regimens today are so much simpler, often one pill once a day.
They are. But the principle is still combination therapy. Usually 2 NRTIs is the backbone, plus a third active drug.
And that third drug is increasingly an integrase inhibitor.
Yes. The new second-generation integrase inhibitors, like dolutegravir or bictegravir, paired with tenofovir and emtricitabine, that's pretty much the global standard of care now. They're potent, well-tolerated, and have a high barrier to resistance.
Now the big question. When do we start ART?
There's no debate anymore. The guidelines are unequivocal. You start ART in all people with confirmed HIV, regardless of their CD4 count or clinical status.
Start early, start now.
Yes, early initiation reduces morbidity, mortality, and transmission.
But
Mm-hmm.
there are a few critical exceptions, aren't there? Times when you actually have to wait.
There are, and it's because of the risk of immune reconstitution inflammatory syndrome, or IRIS.
Explain Iris again.
It's a paradoxical worsening. Your immune system starts to recover on ART, and it suddenly sees a coexisting infection that it was previously too weak to fight.
And it overreacts. It launches this exaggerated, massive inflammatory attack.
Which can be dangerous, even life-threatening.
So what are the specific delay instructions?
For most OIs, the rule is to start RT within 2 weeks of diagnosis. But for cryptococcal meningitis, you must defer ART for 5 weeks.
Because starting earlier increases the risk of dying.
Yes, from severe brain swelling. For tuberculosis, you generally defer RT until 8 weeks of TB treatment have been completed.
Unless the patient is really sick.
Unless the CD4 count is critically low, below 50. In that case, you shorten the delay to just 2 weeks. It's a balancing act.
So once RT is started, how do we monitor it? We know the viral load is the key indicator.
It is. You should see at least a 10-fold drop in the first month. And by 6 months, the VL should be fully suppressed or undetectable.
And if it's not?
That's virological failure. And you have to figure out why. Is it adherence? Is it resistance?
And the CD4 count should be going up.
It should. It usually increases by about 100 to 150 cells in the first year. Once the VL is suppressed and the CD4 is comfortably over 350, many clinicians stop checking it routinely.
Let's talk about the biggest long-term threat. Antiretroviral resistance.
It's the inevitable consequence of that error-prone reverse transcriptase. If there's ongoing viral replication in the presence of the drugs, the virus will find a way around them.
You mentioned the concept of a genetic barrier to resistance. What does that mean in practice?
It's about how many mutations the virus needs to become resistant. Some drugs, like lamivudine or efavirenz, have a low genetic barrier.
One mistake, and they're done.
Exactly. A single point mutation can knock them out. That's why perfect adherence is so important.
And the other drugs?
The protease inhibitors and the new integrase inhibitors have a high genetic barrier. The virus needs to accumulate multiple complex mutations to beat them, which makes them much more forgiving.
And when do you test for resistance?
At baseline, before starting therapy, to check for any transmitted resistance, and anytime you have confirmed virological failure.
And the patient has to be on the failing drug regimen when you do the test.
That's a critical detail. You have to be taking the drug for the test to detect the resistant strains that the drug has selected for.
Okay, let's wrap up with our defensive strategies. Chemoprophylaxis and immunization.
The best defense is a good offense, which is getting the CD4 count up with RT, but while you're waiting for that,
Cotrimoxazole prophylaxis.
a lifesaver globally. It prevents PCP, toxoplasmosis, bacterial pneumonia, even malaria. It's indicated for anyone in stage 3 or 4 or with a CD4 count below 200.
And TB prevention.
Absolutely critical. You start TB preventive therapy, usually with isoniazid, but only after you've ruled out active TB with a symptom screen.
And what about vaccines?
Live vaccines, like MMR, are generally contraindicated if the CD4 count is severely suppressed. You want to wait until the patient is stable on RT with a CD4 over 200.
But some vaccines are for everyone.
All people living with HIV should get the pneumococcal vaccine and an annual flu shot. BCG, the TB vaccine, is permanently contraindicated.
And finally, prevention for people who are HIV negative.
2 big tools, pre-IP or pre-exposure prophylaxis. That's taking a daily pill, usually tenofovir and emtricitabine, to prevent getting infected.
And PP, post-exposure prophylaxis.
That's the emergency measure after a significant exposure. The key is that it must be started within 72 hours of the event. The sooner the better.
Okay. We have covered a huge amount of ground. We've built a clinical anchor that should serve you really well. Before we finish, let's just quickly cycle through the highest field concepts one last time.
Remember the structural keys, the factory takeover model, and those 3 key drug targets, reverse transcriptase, integrase, and protease.
Remember the scorecard. CD4 count tells you the risk, the tiers of terror. Viral load tells you if the treatment is working. And never forget the permanent marker rule for staging.
And please commit that key neurological difference to memory. Multiple ring-enhancing lesions equals toxoplasmosis. A single periventricular lesion equals primary CNS lymphoma.
Our journey today has tracked a disease that has been utterly transformed by science. We started with a fatal illness, and we ended with a manageable chronic condition.
But that very success has created a new and fascinating clinical reality.
As we mentioned, people living with HIV are aging. They're now dealing with accelerated rates of all the diseases of aging heart disease, stroke, dementia.
And it's often complicated by long-term drug toxicity and the sheer complexity of polypharmacy.
So here's the provocative thought we want to leave you with, the future clinicians. The classic HIV specialist was a master of opportunistic infections.
But as the population of people living with HIV ages, and the focus shifts almost entirely from fighting these acute infections to managing complex chronic comorbidities,
How will that fundamentally change the skill set and the primary role of the HIV clinician in the next decade? It's moving far beyond just infectious disease.
it's becoming a discipline that requires a deep, integrative understanding of all of internal medicine. Mastering the fundamentals today is what prepares you for that evolving future.
Thank you for joining us for this deep dive. Until next time, keep digging.